The next session, that is on high platelets, that is essential thrombocytosis. As you must be all aware that it is a myeloproliferative neoplasm by the new nomenclature. But though it is a neoplasm, the risk of evolution to acute leukemia over 10 years is less than just 5%. There are certain other things which are more common and worrisome about essential thrombocytosis, which definitely would like to know from Dr. Seema. So I would like to invite Seema. Is there any introduction slide there? If it is not there, I can introduce herself because I know her for so many years. Dr. Seema is our own hematologist. She is MD medicine from Bhopal Medical College, and after that she got trained in hematology for 2-3 years at Pune under Dr. Shashi Apte at Sayadri Hospital. After that, she has been working in Baroda as a hematologist, oncologist, and transplant physician for so many years. She is the one who has pioneered and started bone marrow transplantation in the city of Baroda, and we are all proud of you, Seema. So kindly go ahead with the presentation.
Thank you, Dr. Bide, for kind introduction, and good evening all. And today, after this excellent talk by Dr. M.B. Agarwal on high WBC, I'm going to talk on high platelets. So if you see diagram, these platelets are these tiny cells as compared to red cell and WBC. Platelets are little one. But if this little one is in high number, it can create havoc. So everybody knows hemostasis and thrombosis as a function of platelets, and it stops bleeding, and you really require to form a primary hemostasis and plug to stop bleeding. But there are multiple other functions of platelet, like in inflammation, host defense, tumor biology, and vascular tone, and all these functions we are not very much, everybody is not very much aware, but all these play part in various way to increase the platelet count. So by definition, when platelet count is more than 450,000, it is defined as thrombocytosis. But believe me, if you see 100 patients of thrombocytosis, 80% are reactive and can be managed by physician or clinician. They don't require a hematologist's opinion. There are hardly 80% of patients who require hematologist's opinion because they harbor underlying hematological disorder. So in next 20 minutes, we'll see how to approach case of thrombocytosis. And when I was preparing this lecture on thrombocytosis, I gone through various articles, and this was a really best article I found, and it is authored by none other than the father figure in the field of myeloproliferative neoplasm, Professor Teffrey, and it was published in 2012 as an ASCO post, but it is still relevant, even though we have progressed a lot in as far as diagnostic workup is concerned or treatment is concerned. So basic approach is same. You may have a different diagnostic approaches, but you should have a proper basic approach and you will reach to the cause. And what is important in thrombocytosis, or for that matter, for diagnosis of any diseases, reach to the cause and then treat. So these are the steps which has been mentioned by Dr. Teffrey: history taking, examination, and then 4 steps of workup, which will clinch you the diagnosis. So in 4 steps, first is history, and history is basically to get a hint whether patient is having reactive thrombocytosis or primary. So if patient has a history of blood loss, microcytic anemia, or infection, especially tuberculosis is an infection in India which can cause a very high platelet count. Apart from infection, various inflammations like autoimmune disorders, trauma, burns, and even malignancy like secondary solid organ malignancies with metastasis can also cause high platelet. Apart from that, splenectomy may give you a false rise in platelet count. Why? Because normally in circulation, when platelets are in circulation, 1/3 of platelets reside in the spleen. And when spleen is taken out, this 1/3 goes into circulation. And you feel that platelet count is high, which is not so. So similar phenomenon can happen in sickle cell disease patient, because in sickle cell disease you get a auto splenectomy because of the infarct, and that can result into the high platelet count. They don't require any other treatment or investigation, just treat the cause and you get the result. So if you have a patient with unexplained vasomotor symptoms like erythromelalgia, flushing, pruritus, headache, or constitutional symptoms with unexplained fever, sweat loss, or thrombosis, especially young patient, recurrent thrombosis in unusual sites. What are the unusual sites? The usual site is lower limb. Apart from that, if patient gets thrombosis in the cerebrovenous sinuses or portal vein or splenic vein, then with thrombocytosis, then think about primary thrombocytosis. If patient is complaining of lump in abdomen, there is a discomfort, not able to eat well, and splenomegaly is there with thrombocytosis, yes, it has to be a primary myeloproliferative neoplasm. And one of the gastroenterologists very jokingly always tells me in Baroda that if patient is having splenomegaly with high platelet, Seema, it is your case, I'm not going to touch. And if patient is having splenomegaly with low platelet, it is my patient, I'm going to do the upper GI scope. And he is absolutely right. If splenomegaly is there and if your platelet count is irregular, you should suspect that whether it is a myeloproliferative neoplasm. To confirm the findings of history taking, you need to do a proper examination, find out all the findings which have been noted in history, confirm it by examination, and then go ahead with the 4 steps which has been mentioned by Professor Teffrey. And the first and foremost important step is review CBC peripheral smear, then go for inflammatory markers. If it is not there, then go for a screening of mutation, which will tell you whether patient is having underlying primary thrombocytosis or not, and then confirm it with the bone marrow examination. So we'll go one by one. The first step is review of peripheral smear, and it gives a lot of information. So after history and examination, the first thing you have to do is, if patient is not affording, at least get the peripheral smear done, which can be done even free of cost. And our pathologist friends, they can be helpful if for such patient to give a clinch or hint for a diagnosis. This is for all those who have not been to pathology department and see the slide. This is the normal slide. These are the RBCs, platelets, small tiny cells, and this is lymphocyte. So if it is a essential thrombocythemia, you get platelets in clumps like thrombocytosis. And if you see this picture, if your pathologist friend, colleague tells you that he is seeing a lot of platelets in clumps in the peripheral smear, you know that you are going to refer this patient for marrow or mutation study to confirm the diagnosis. If pathologist tells you that your this peripheral smear is showing Hoyle-Jolly bodies, which are nothing but the nucleus reminiscents of the RBCs, which are normally taken up by the spleen, but if patient had undergone splenectomy, or if it happens because of the disease like sickle cell disease, autosplenectomy occurs, then these cells remain in the circulation, and this is a hint for whether this high platelet count is because of sickle cell disease or splenectomy. Then this tells you that there are a lot of polychromacy RBCs, macrospirocytes, and NRBCs. And this tells you that patient is having hemolysis, and because of hemolysis, their marrow is stressed up and throwing away a lot of platelets. This picture again tells you that there are teardrop cells shift to left, and this leukoerythroblastic picture is usually you see in the myeloproliferative disorder. So again, you need to confirm it with the further investigation. This is a classical case which has been discussed by Dr. M.B. Garwal very well in the previous lecture. Shift to left with the basophilia. Pathologists can pick up this without doing even BCR-ABL, that yes, this is BCR-ABL, and then you don't need to do any other workup but BCR-ABL for this patient. This shows the dysplastic neutrophil, and in dysplastic neutrophil, the point towards the diagnosis is myelodysplastic syndrome, especially if you have a high platelet count. 5q deletion patient shows high platelet count with myelodysplasia, and they get a very good results with the simple oral drugs. So second step, after reviewing the peripheral smear, the second step is to get the inflammatory marker done. The most common inflammatory markers, if you do not have a specific symptoms or examination, any finding, then get at least ferritin and CRP done. If it is normal, at least you do the further workup based on the clue from the history and examination, basically to rule out infection, inflammation, solid organ malignancy, or blood loss. So whatever you get the information from history and examination, accordingly do the second phase investigation to confirm the underlying cause. If you don't see any underlying cause and you don't think that patient is having reactive thrombocytosis, the JAK2 mutation should be done, and basically JAK2 is the mutation which is seen in the majority of myeloproliferative neoplasia. MPN stands for a myeloproliferative neoplasia. And in essential thrombocythemia, you get the high platelet count. But apart from that, you can get high platelet count in polycythemia rubra vera as well as primary myelofibrosis. So JAK2 mutation is present in a majority of the time, but in minority of time, you may get other mutations like calreticulin, MPL, or very few patients may show no mutation, and they are triple negative mutation patient. These patients may harbor some other mutations like this panel of mutations which actually carry a bad prognosis. And step 4 is, if your diagnosis going towards the primary thrombocytosis, get the bone marrow examination done, basically to differentiate between whether I'm dealing with essential thrombocytosis or CML or polycythemia rubra vera or myelodysplastic syndrome or primary myelofibrosis. It is very easy to differentiate or diagnose on slide of the peripheral smear and bone marrow these three disorders. But essential thrombocytosis and early primary myelofibrosis, pre-fibrotic state, they are very close, and it is very essential to differentiate between these two. And for my pathology colleagues, this is the very good slide which I found was narrative and very descriptive about how to differentiate essential thrombocytopenia from the primary myelofibrosis. What you see in primary myelofibrosis in the pre-fibrotic stage is increased cellularity, whereas in ET, the cellularity does not increase. Second thing which you see is the erythroids are depressed in primary myelofibrosis, whereas in ET, the erythroid components remain normal. The third important difference is, if you see the megakaryocyte abnormality, these megakaryocytes are loosely placed, not densely placed like here, and their nucleus is hyperlobated, whereas in primary myelofibrosis, it is a hypolobated with almost dysplastic nucleus. This again tells the same thing which I have narrated in the previous slide. So why it is important to differentiate between ET and primary myelofibrosis or polycythemia rubra vera is because their survival, long-term complication is different, and that is why it is important to differentiate. Even if we diagnose that platelets are high because of primary thrombocytosis, you need to pinpoint whether it is ET, PV, or primary myelofibrosis. So this slide show you why I tell it is important to know, because if this tells you that overall survival in essential thrombocythemia is better compared to primary myelofibrosis, leukemia-free survival is also best in ET compared to primary myelofibrosis. When you compare with ET with polycythemia rubra vera, you can see the fibrotic complications are also less in ET compared to PV. And if you see the thrombotic episodes are highest with PV, polycythemia rubra vera. Then second is ET, and third is PMF. So highest is 26%, PV 22%, and 10% primary myelofibrosis. So most of the time when the diagnosis of essential thrombocythemia is made, many patients ask whether am I suffering from the cancer. So it is yes and no. It is yes because yes, it is one type of chronic neoplastic process. But no, because they don't require any chemotherapy to have a control on this platelet count. If you see the natural history of this patient, the possibility or probability of evolution into acute leukemia in ET is less than 2% over a period of 10 years and less than 8% even if they survive for more than 20 years. If you ask the risk of myelofibrosis, which may evolve over a period of time, that is also very low. It is less than 5% for in 10 years and less than 20% over a period of 20 years. Then why we are worried, and what do we do when the diagnosis of ET is done? So if diagnosis of ET is done, that the most important thing which patient should know is, even if you are not going to be treated with the chemotherapy and you are not going to get admitted for the aggressive treatment like acute leukemia, you are at the risk of thrombosis. So risk of thrombosis in PV is highest, followed by ET. But in the ET follow-up as well as PV, at diagnosis, even if it is 22 or 23%, follow-up of these patients over a period of time increases the risk of thrombosis. So what you need in follow-up is to see whether patient is having any risk of thrombosis, and it should be definitely treated properly to avoid any life-threatening complication. The other non-life-threatening complication which bothers patient more is a pruritus and microvascular symptoms, which should be tackled with the symptomatic treatment. So having this in background, I am going to show three cases. Case one is 54-year-old female who had no comorbidities and she was asymptomatic. The examination did not show anything abnormal. So next thing which I did was a peripheral smear examination. That peripheral smear examination also didn't give any clue. And her other biochemistry, CRP, ferritin, everything was normal in spite of the fact that platelets were around 765,000. So we did this other inflammatory markers like the ANA, RF factor, serology, but it was normal. Then we did the malignancy markers to find out whether there is a hidden malignancy or not, but they were also normal. Sonography was normal. So ultimately mutation test was done and which was negative. Bone marrow examination was, the patient was very anxious. Why she's having high platelet? She's harboring some cancer. Let us do the bone marrow. The marrow examination was done, which didn't show any abnormality. And she was almost paranoid. No, I am having cancer. Please do something and find out. So the PET scan was done and that also didn't show any abnormality. So finally, she went for a first, second, third opinion from different parts of India. Everybody said that all the reports had been done and they are normal, even though thrombocytosis was persistent. And then she lost for follow-up because she was fed up with doing investigation and there was nothing coming positive. So she thought she has to live with this high platelet count, and she just remained at home without doing anything. So Kintan, this is a polling question. So my question, Kintan?
Yes, ma'am.
Kintan?
Yes, ma'am.
Yes. This is polling question for all audience. Just poll. Looking at this history, examination and investigation, whether this patient is having essential thrombocytopenia, reactive thrombocytosis, or it is idiopathic. Answer the question.
Two more seconds to go.
Yeah. So, okay, I was expecting this answer, idiopathic, and if Dr. Shashi Appe is there, he will laugh at this answer, because he used to say there is nothing idiopathic in science. Even though we, in many conditions, we have to label it idiopathic, but he used to always tell me, if you are diagnosing it is idiopathic, then doctor is idiot and patient is in pathetic condition. So never diagnose idiopathic unless you are 101% sure that patient is not harboring anything. And you are right, all those who have said idiopathic, they are right, because we couldn't find anything. So how we are going to label it as a reactive? But in such patients, what you need to do is just follow them up every 3 monthly or monthly if they are having any problem, and then you get the answer. Like this patient, after 1 year, she got admitted with the gynecologist, and I got frantic call from gynecologist that patient is having ovarian mass with high CA 125. Her platelets are high, and she wants to do the surgery. She wants to remove the tumor. What to do, and how to prevent the post operative thrombotic complications, and that is why I was involved. So when I saw the case, I was really very happy. Hush, at least we got the answer why patient is having high platelet count. Post-operatively, patient had undergone surgery. Post-operatively, she was put on LMWH to prevent the thrombotic episode, but after 2 to 3 weeks, her platelet count decreased to normal. And then I reviewed with the literature. There are no much reports on the hidden or silent CA ovary associated with the high platelet. There are 1 or 2 case reports of advanced CA ovarian cancer with the high platelet count. But this is something which I had never seen in my life. But this tells me that even in a stage where the ovarian cancer is not visible by the CA125 or on the sonography, there are secretions of IL-6 which stimulates TPO and increases the platelet count. So these patients should be kept on the monitoring to pick up the diagnosis early. The second case is simple. This is 14-year-old male presented with history of fever, weight loss, cough for 2 to 3 months. And on examination, there were crepes in the right upper zone. Rest of the examination was normal. And he was found to have rising platelet count, and platelet count increased from 250,000 to about 10 lakh in 2 months. So his CBC showed, review of the CBC showed hemoglobin 9 with MCV 86, TLC normal, platelet 10 lakh 45,000, biochemistry LDH was normal, CRP, serum ferritin borderline high, serology negative. So this patient, I advise only X-ray PA view. Bone marrow examination on JAK2 mutation was not done, and X-ray showed this abnormality. So I would like to know from all of you, what is the cause of thrombocytosis in this patient? Kintan, this is polling question. Is it reactive or essential?
Five more seconds.
Yes. 94% tells that it is reactive. Yes, absolutely right. It was a case of pulmonary tuberculosis, and even though the platelets count crosses more than 10 lakh, nothing to worry. You treat the pulmonary tuberculosis, the platelet count will normalize. And that is what happened with the second case. So the lesson learned from these two patients is no need to do bone marrow hurriedly in reactive thrombocytosis. You can wait. Aspirin does not, aspirin is not indicated. Like even if platelet count is more than 10 lakh in that patient of pulmonary tuberculosis, no need to give aspirin. It will settle down with the treatment of underlying cause. And these patients definitely require basically to find out what is the underlying cause, and you treat the cause and you will get the normalization of the platelet count. So next patient is interesting. She is a 34-year-old female presented with recurrent pregnancy loss. There were no comorbidities. The APLA and usual gynec workup for bad obstetric history did not reveal any abnormality, but her CBC definitely showed abnormality in a form of high platelet count. And the previous record also showed persistent high platelet count, more than 4,50,000 for more than 1 year. Other reports were normal. So this was pointing to a pregnancy loss is nothing but we always see in the increased thrombotic conditions. So pregnancy loss recurrent with the high platelet count definitely pointing towards the primary thrombocytosis. So JAK2 was done, which was negative, but this patient showed Carl reticulin positive. Bone marrow examination was done, which again confirmed the diagnosis of essential thrombocythemia. Why it was necessary to do bone marrow examination? Just to differentiate between primary myelofibrosis and ET. So this patient was having essential thrombocythemia. She again expressed her desire to become pregnant, and I treated her and she became pregnant with the platelet count of around 4,15,000. Now the question for audience is, if she becomes pregnant, whether pregnancy should be continued, because the cytoreduction medicine is not usually allowed in the pregnancy. So whether it should be continued or it should be terminated.
Two more seconds.
Yes, majority feels that pregnancy should be continued. They are right, because in pregnancy, even if hydroxyurea is not indicated or should not be given, pegylated interferon or interferon can be given. And with that, if your patient is maintaining good count and maintaining normal liver function with the normal WBC count, that can be given along with low molecular weight heparin and low dose aspirin. This patient delivered full-term healthy baby boy after 9 months. So basically, in essential thrombocythemia, once we diagnose, we divide this patient in whether they are in low risk or high risk. The low risk are those patients who are less than 60 years of age, no history of thrombosis, and no JAK2 mutation positive. They can be treated with only aspirin and no cytoreduction. High risk patients are those patients who have a history of thrombosis or age of more than 60 years or JAK2 mutation positive. They should be treated with aspirin and cytoreduction. Cytoreduction with hydroxyurea is the first line of treatment. However, there are certain patients who will not respond or refractory to hydroxyurea. They can be treated with interferon, PEG interferon, anagrelide, and busulfan. Out of these two, interferon and PEG interferon, can be given during pregnancy also. This is the new drug ruxolitinib, that is a JAK2 inhibitor, which has been launched in 2017, but it is not superior to hydroxyurea or any other cytoreduction agent, except in the patient where patient is having intractable pruritus and constitutional symptoms because of marked splenomegaly. These two symptoms basically do well with JAK2 inhibitor. So in conclusion, I would like to give this message to all the audience is in routine practice, majority of patients with high platelet count have reactive thrombocytosis and can be managed without hematologist referral, especially when the diagnosis is defined by the initial evaluation or the platelet count response as expected to the observation or the treatment. Hematologist interference or referral is needed if platelet count does not respond as expected to observation or treatment of the reactive cause of thrombocytosis, or diagnosis is not established by the initial evaluation, or there is any doubt about the possibility of myeloproliferative neoplasm or primary hematological disorder as a cause of thrombocytosis, or bone marrow examination is indicated. Patients with thrombocytosis require urgent evaluation if they are hemodynamically unstable or are having extensive thrombosis or excessive bleeding or presence of blast on initial smear evaluation, or patient is pregnant, or patient is having platelet more than 10 lakh. Because in patient is more than 10 lakh, especially in ET, these patients are at the higher risk of bleeding instead of thrombosis if they are having acquired von Willebrand disease, which is possible in some of the patients. With that, I will end my lecture and I will be happy to answer your queries after Dr. Shashi Apte's lecture. And thank you very much. Wishing you all very happy new year. Stay safe and healthy. Thank you so much.
Thank you very much, Seema. It was a wonderful presentation focusing on what is important, and you gave a very nice approach to case of high platelet count. I myself learned a lot today, and I am sure the participants will definitely agree with me and maybe having many more questions to ask you. But let me tell them, we will be taking the questions after the last and the third session is over. The next and the last topic to be discussed is about high RBCs, that is polycythemia. Whenever we come across a case of polycythemia, some common questions crop up in our mind which need to be answered. First thing is it primary or secondary? Is blood donation is the treatment option for polycythemia? One fact which I was not aware of is that polycythemia over a period of time can actually evolve into a refractory anemia or pancytopenia. That definitely I was not aware of. There are many more such surprises in polycythemia, and to tell us about that, let me invite Dr. Shashi Apte. He's a hematologist from Pune, MD Medicine from KEM Hospital, Mumbai in the year 1991. He has got a professional training in hematology from CMC Vellore from 1991 to 1994. He's a FRCPA from West Mid, Australia, practicing as a hematologist, oncologist, hematologist, and bone marrow transplant physician at a super specialty Sahyadri Hospital, Pune for such a long time. He's a tutor and mentor of Dr. Seema, that is, and definitely he's a guest lecture for every year with Hematology Updated Baroda. So, sir, we have got a special affection for you, Dr. Shashi Apte. Over to you, sir.
Thank you, Dr. Vinay. Can you hear me?
Yes.
Let me just open my...
Yes, we can see your slides also now.